Welcome everyone to what is now the 8th lecture in our series on current issues in Labour's economic policy. My name is Ewan McGaughey, and today we're talking about the National Health Service prevention and care. And we've got two fantastic discussants. We'll do the usual thing. I'll talk for the first half, and then we'll go into a discussion with them and all of you. First of all, we've got Professor Beck and Malby, who's come down from the University of York, and also has experience on integrated care both for the West Yorkshire National Health Service, or the NHS in West Yorkshire. And we've also got Dr. Johnbosco Nwogbo, who is slightly delayed because he was doing an interview for Channel 4 News. I think it's fair that Channel 4 is much more important than this. So hopefully he'll be joining us shortly. Lots to talk about. As usual, we'll start off with what the political pledges have been. So Keir Starmer, when he was running for the Labour leadership, said we want to set a national goal for well-being to make health as important as gross domestic product. Invest in services that help shift to a preventative approach, stand up for universal services and defend our NHS. He says he wants a Clean Air Act to tackle pollution locally. And he says that public services should be in public hands, not making profits for shareholders. We need to end outsourcing of our NHS. And when it comes to the Manifesto earlier this year, just before the 2024 election, it said this. With Labour, the NHS will always be publicly owned and publicly funded. Note that there could be private provision outside the NHS, but the NHS itself is publicly owned and publicly funded. We must change the NHS, this is the big idea, so that it becomes not just a sickness service, but able to prevent ill health in the first place. Too many patients have seen their treatment affected by strikes. Labour will reset relations with NHS staff. And then a bit more on the prevention idea. It says elsewhere in the manifesto, Labour's going to ban vapes from being branded and advertised to appeal to children and stop the next generation from becoming hooked on nicotine. We face a childhood obesity crisis, it goes on a bit later, so Labour is committed to banning the advertising of junk food to children along with the sale of high caffeine energy drinks to under 16s. So if we sort of put these all together and change them around a bit, we've got three main ideas that we're going to go through today. First of all, this idea of shifting to prevention away from being a sickness service, and we've got special emphasis in pledges and policy documents on nicotine, on junk food, and on toxic air. Secondly, the NHS is to be publicly owned and funded. We want to end outsourcing, and we want to reset relations with staff. And thirdly, there's this idea which we talked about before when we did banking and corporate governance, of setting a national goal of well-being to make health as important as gross domestic product. So what we'll do as usual is we'll look at the human rights background, what the actual law is in the UK, we'll set that against where the UK is in international rankings and with some of the data, look at the models for reform and the benefits of cost for reform before we get into discussion. Starting with human rights, it's very clear that healthcare is a human right. It's a universal human right acknowledged since the Universal Declaration, but it's at a high level of generality. So the Universal Declaration says everyone has the right to a standard of living adequate for health and well-being of himself and his family, including medical care and necessary social services. And so you see, that's not a right to healthcare directly, it's a right to a standard of living that's adequate for healthcare. Then when we get to the treaty, which kind of codifies and expands upon the Universal Declaration, the two international covenants, this one on international covenant on economic, social and cultural rights in 1966, it says a bit more. It says, firstly, there's a right of everyone to enjoyment of the highest standard of physical and mental health, so they were ahead of their time, emphasising mental health like we are now. And then in sub-article 2, it says, there should be a focus on improvement of all aspects of environmental and industrial hygiene, the prevention of all sorts of epidemics and endemic diseases, so prevent diseases from occurring in the first place. So, also ahead of the Labour Manifesto by half a century. And the creation of conditions which would assure to all medical services and medical attention in the event of sickness. And so what you notice here is, unlike, that they could have just said everyone has the right to healthcare and they have a right to that from the state. It's not saying that, because what these treaties are doing and what international human rights law leaves open is that we could organise our health system on an insurance basis, where there's private provision, private running, or non-profit running separate from government, and then the government acts as a social insurer, and that's, we'll see a bit later, a model of around sort of half of the countries in the OECD, or we could do what we have in the UK, which is directly provide healthcare from the public sector, known as the Bismarck model of insurance, or broadly the Beveridge model. So the international treaties are agnostic about how we organise our healthcare system. And I think it's useful to emphasise that we go very much beyond the minimum standards that international law sets. So the goal of the Minister for Health in 1946, who set up the NHS, Nye Bevan, was this. Money ought not to be permitted to stand in the way of obtaining an efficient health service. It's repugnant to a civilised community for hospitals to have to rely upon private charity. So the very idea of money and monetary transactions in healthcare was repugnant to the people who set up the NHS. It was meant to be provision from the public, what the Americans would call socialised medicine. And I think it's also worth adding, because we'll touch on this, a couple of, or one of the human rights relating to education, because this comes into trainings for doctors and nurses. There's also a right, we're going to go into this in much more detail next week, but there's also a right to free education under the International Covenant, and in particular, the right to the progressive introduction of free education at higher education level. So there is a right to free university, no tuition fees in international law. And that was back in 1966, but if we go back even further, you can find the same thing in the Hippocratic Oath, which you might have heard of, the oath of doctors and physicians. I swear by Apollo, the physician, that you do lots of things, but mainly if somebody wants to be taught medicine, then it says, I shall teach them this art without fee or indenture. So the idea of medical training without any fees is very old. But how do we achieve these human rights and political aspirations in reality? They're very high level. How do we achieve them through the law? So let's go through that now. And welcome to everyone. Glad you managed to find it. Three parts. First of all, what are the rules surrounding prevention, public health? Second, what are the rules on NHS finance and governance? And thirdly, about this idea of health and well-being in contrast to GDP. So let's go into prevention and the framework first of all. Now, the main thing is at the top, and then the rest is on care. But so at the moment, public health duties are primarily under the control of the Secretary of State for Health. So that's Wes Streeting. Or previously Matt Hancock. There's a pandemic and we've got to take public health measures. Then Matt or Wes have the power to take public health measures, but they delegate. It used to be to an agency called Public Health England. That got split up after COVID. It's now the UK Health and Security Agency, or the Office of Health. I think it's Improvement and, I've forgotten what my abbreviation is, but the Office of Health, like Off Health. So main thing is it's not the NHS that takes public health measures, it's the government. Of course, one of the problems that we've got is that if you want to change the way that public health works and you want to try and tackle some of the causes of ill health, then that potentially means rulemaking across lots and lots of different kinds of industries and fields of the economy. And there's no power for the NHS to do that yet. But it is possible under the NHS Act, Section 7A, for the Secretary of State to transfer their public health functions to NHS bodies. And they do that in sort of discrete ways, but nothing big that we'll get into later. Then we've got social care, and this really matters for elderly people, so social care, particularly after retirement. That is not within the NHS. Social care is under the control of local councils. There's loose state supervision. A lot of care homes, most care homes are provided privately. Organisations like Southern Cross, now insolvent, who have had very serious problems with standards, including mismanagement and even abuse of elderly residents. So we see a House of Lords case called Weil and Birmingham about whether people could sue under the Human Rights Act for breach of standards, and the answer was no, they couldn't, because it's a private body, not a public body. The regulations are in the Care Standards Act from 2000. Local councils have a duty to accommodate people and give services for care, but they're allowed to impose charges, and that's been the case since the National Assistance Act of 1948. They've got a duty to meet the needs of people, give assistance at home, provide recreation, comfort, meals, communications, and these duties are heightened when you've got people with disabilities. But the problem is that the local councils' budgets are very limited, and again, they can charge for the main services that they do, particularly care homes. There was a proposal around 2014 that there should be a cap on the amount of money that people have to pay to the care service at £72,000 a year, and they couldn't, the government or parliament couldn't even agree to cap at that level. So that's the picture on public health and social care. Now onto the NHS. This is the way it's financed in this sort of flow chart. Imagine just money, like how does money go through the NHS? And this is my attempt to represent it. I mean, first of all, you've got the Department of Health, so it gets money from the Treasury, from general taxation, and it gives that money to NHS England, also known as the Commissioning Board, and then NHS England, different system in Scotland, Northern Ireland. NHS England distributes money to integrated care boards, used to be smaller bodies called clinical commissioning groups, and then they give money to hospitals like NHS Foundation Trust. So, how is Guy's and St Thomas's Hospital funded? Well, the answer is through that chain. And so when you visit a GP, it's getting money from NHS England directly, not necessarily through the extra step. We've also got specialist doctors being funded by NHS England. Private companies can also get money from integrated care boards. And then we've got a system of different regulators, the National Institute for Clinical Excellence, the Care Quality Commission, Health Watch, who provide various services overseeing hospital standards or approving drugs and medicines, and they're funded by NHS England. The principle of this whole system, just like Nye Bevan started with, is in the NHS Constitution for England. Access to NHS services is based, or should be based, on clinical need, not an individual's ability to pay. So that's the sort of starting principle. But then there's lots of ways in which that principle is rolled back on. So one of the first things, so free at the point of need, yes, but private money comes into the NHS in a number of ways. One of the first things is the NHS trusts can borrow money privately if the Secretary of State approves. So let's say UCL is building a new hospital, as it did a couple of decades ago. It can borrow money from the private sector, and instead of the government borrowing at sort of low public borrowing rates, the private sector might have a higher rate of interest. And what they typically do is they say, we'll build the hospital for you, but then you give us lease payments will lease the hospital back to you for 30 years, and that can end up costing significantly more than how much it would cost if you just borrowed the money up front. But the advantage is that the money is off the government's books for the amount of debt the government has, because through this slightly different ownership arrangement, it's pretending that the government isn't borrowing money directly. Okay, so that's the private finance initiative. And then we've also got charges. So access to NHS services is based on need, not an individual's ability to pay. But as we all know, dental services are not free at the point of use. Optical, so for eyes, and you've got you have to pay for glasses and so on. And you have prescription charges for drugs, medicines, or pharmaceutical services, unless people qualify on the basis of need for reimbursement of their costs. So that's all in the NHS Act, sections 172 to 81. There are exceptional charges. And then the big thing that happened in 2012 is that the NHS can do, an NHS Foundation Trust can do up to half private work. So, Guy's and St Thomas's Hospital has, rooms above the public wards for different operations, or maternity ward, where you can get private care, and people who work in the NHS can do their public work, but then they can also offer private work, and then they can even say to you, well, there's a very long waiting list on private work, but you can see me, the same person, and pay me, and I'll see you a lot quicker. And that's happening all the time now. It's happening everywhere, mainly because in 2012, the cap on the amount of private work that trusts could do was 2%, and it was raised to less than half, so 49.99%. So that's in section 43.2a of the NHS Act 2006. How are all these bodies governed? Same chart. Let's sort of work through, who appoints who. So NHS England is appointed by the Secretary of State. That's Wes, and they're the sort of starting point for delivering all the money, as we said. Integrated care boards are also appointed by the Secretary of State, but you also have 3 members of the ICB nominated by NHS trusts, and staff who provide primary medical services. And you also have a representative of councils. NHS trust boards, which run hospitals, are appointed by the Secretary of State, but they're usually the ones that aren't sort of as good and can get foundation status, which have more autonomy. They can do the private borrowing. If you're an NHS Foundation Trust, then the directors have to be, or can be, between 1/3 and 1/2 elected by the staff. And there's also provision for representation from local councils and a university if you've got one in your local area. So if you look at the King's College Hospital Foundation Trust, or the Guy's and St Thomas's Foundation Trust, on its board there will be a representative from King's College London, as well as some representatives from the staff. And then GP practices are actually private practices. They're mostly partnerships, and their terms are set, like how much the doctors are paid, are set in regulations from the Secretary of State. But really it's a system of collective bargaining and negotiation. They have to have patient participation groups. And what about staff pay? A bit more on that. Because, of course, this was one of the causes of, and the system not working so well, was one of the problems that led up to all the strikes in the last couple of years. So really it starts with the Prime Minister and the Treasurer in setting how much the NHS staff are going to get paid through collective bargaining. They've got notionally independent bodies called pay review bodies. These were set up from sort of 60s to 1980s, changed in the 1990s, which are supposed to give recommendations that are independent to government, but the pay review bodies are appointed by government, so they're really not that independent. So what it really comes down to is collective bargaining. Pay review bodies have this sort of notional independence. And there's two main ones. There's one for doctors and dentists. There's another one for all the other staff in the NHS. Pay in the NHS is, well, because people have to go through education, a lot of pay is going to pay off student debt. So nurses and doctors and dentists, like anyone who goes to university, are going to be paying between £9,250, shortly going up to something over £9,500 a year. If you're a home student, to £45,000 or perhaps more if you're an international student each year. So the average debt for a nurse in 2024, nurses had to pay off, was £40,000, and the average debt for a doctor in 2021 was £71,000. Okay, third area. So health and well-being against GDP. And so for those of you who are at the banking and corporate governance lecture, this will sound familiar. There's no concept of GDP written down in statute. Gross domestic product is the concept that we sort of use to measure growth. If GDP is going up, that means that we're growing. And it adds up all economic activities, all the contracts that are taking place, all the things that are bought and sold. And the problem is that it includes harmful things, pollution and damage to health and well-being. So if we look at a Treasury document on what GDP is, this is a quote from it, GDP is calculated in three ways, adding up all the money spent on goods and services minus the value of imports plus exports, that's the expenditure method, or the money earned through wages and profits, the income method, or the value of goods and services produced, that's the output method, looking at companies' accounts. All three methods are supposed to theoretically produce the same number. And then it says dramatically, GDP matters because it shows how healthy the economy is. But the problem is that actually GDP also contains things that are not just healthy but very harmful. GDP is measuring harm quite a lot of the time. So to give you just three examples related to health, GDP will go up if health services are moved from the public sector, where there are no prices or fewer prices and fewer transactions, everything is sort of kept in-house, to the private sector, and now there are contracts and there are exchanges, even if in essence the same thing is being done. But so before you didn't have markets, now you do have markets, and therefore it's measured in the calculations for GDP. So if that happens, GDP will go up, even if health outcomes are worsening. And a very simple example to illustrate this intuitively, in America, you have a private healthcare system, lots more spending on healthcare, terrible outcomes, some of the worst outcomes in the developed world, and I'll show you some data on that in just a sec. Secondly, if companies make money from polluting, so toxic air, dirty rivers, when they make profit, GDP is still going up. So water companies that profit when they're putting pollution into the rivers are adding to GDP, even if it's a legal activity. And this is one of the really perverse things, like GDP does not count the drug trade, it doesn't count prostitution, it doesn't count those things that are sort of classically illegal, but it still will count profits from companies, even if they're doing things that are illegal activity. And also if companies sell junk food, nicotine products or polluting vehicles and they profit, GDP is going up. And so actually none of this really does express, as the Office of National Statistics and the Treasury document said, how healthy the economy is, because even in its own narrow terms, the economy is becoming less efficient in these examples in allocating resources and having externalities and the harm to people who produce. And actually there was an op-ed in the Financial Times just yesterday by Chris Giles on this very topic saying, well, everyone wants to replace GDP, but actually it's really not that easy, ha, 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 ha. Chris Giles says GDP is really important because it's a gauge of how money flows and the resources available to households and government to consume and to invest. So we should keep GDP, he says, as a measure of economic activity, because that's what it's good at doing. You should measure the other things elsewhere. But that just is not true. It is not a gauge of how money flows and the resources available for households, because in these examples, which are just a few of the examples, it's actually making households poorer. It's creating fewer resources for government to consume and invest in, and for everyone else. And so that's why the pledge that Starmer originally made for a new measure of well-being alongside GDP is important. Okay, so that's the sort of legal background, and now let's look at how the UK performs in this system compared to other countries. And so we'll go through life expectancy, obesity, nicotine, air quality, and the costs of the NHS compared to abroad, and I think we'll touch on GDP as well. Okay, so this is life expectancy in the UK since 1840, in the blue line that goes up and up and up, and that's good news. And in the dotted line, and the light blue line coming down, that's infant mortality. And so what you can basically see is that you start to get significant changes as we get our first Public Health Act in 1848. This is the first system of health insurance, the National Insurance Act. Then here we move to the National Health Service Act. And the Public Health Act 1904 is another significant changing point. So these two things working together, at the time I think that you can appreciably see a change in the trajectory of life expectancy and infant mortality. But look right up the top there. Something happened to life expectancy in 2012, coincidentally when the Health and Social Care Act was passed. So basically life expectancy has more or less stagnated since 2012. It obviously went down with COVID and it bounced back up again, but we've been in the stagnant period for just over a decade now. If you compare the UK to other countries, we're doing all right against these countries, but if I put more in, we're not doing so well compared to the OECD. But I wanted to show you these ones in particular, because you can see how badly America is doing. Richest country, or one of the richest countries on earth according to GDP, but roughly in 1990 it started going far, far worse than it had been doing before. Australia and Spain are doing quite well. Spain has an NHS system, Australia has an NHS mixed with a private system, and the UK is sort of with Germany. We've just got a little spike in life expectancy after recovery from COVID. We'll see where that goes. The major causes of death in the UK are from I think leading causes of death are from three main sources. The first one is old age, so that accounts for about 11.5% of deaths, so dementia and Alzheimer. The second main cause of deaths is heart failure, and so that's closely associated with poor diets, fatty foods, drinks, and that is related to the business models of big corporations like Sainsbury's, KFC, McDonald's, Coca-Cola, Nestle, that manufacture a lot of the products that are at the root of the problems behind heart failure. And the third main cause of death in the UK is respiratory diseases, adding up a few different things, and that is coming predominantly from air pollution. So again, companies like BP, Shell, or if we look at the tobacco industry, these are the companies that profit from the harms behind death in the UK. If we look, so that's for all age groups, but if we look at young people in particular, the leading causes are a bit different. It's suicide, and so anxiety and depression are often behind suicides. We'll be talking about big tech and social media in a couple of weeks' time. Road accidents, and drugs and alcohol excessive use. The UK is doing pretty badly on a lot of indicators, but I want to highlight three because where Labour's policies are focused on. So firstly, obesity. You can see this is the ranking for obesity. The UK is right down that end. The dark purple is measuring obesity. The light purple is measuring the percentage of people who are overweight. So you can see that we are actually the third worst. We've got 26% of people who are obese, and so that is just behind the United States and Chile. So that's bad. The obesity rate has been going up very significantly. So back in 1990, it was around 14% of people who were obese. It's been climbing and climbing up to 26% now. We're the third worst for binge drinking. As we all know, the UK is just behind Denmark, which I find surprising actually, and Romania. We're doing quite well on smoking, but a lot of the progress is being eaten away by the growth in vaping. So this is a chart from The Economist. Percentage of people smoking is going down, but a lot of people are being hooked on nicotine in a slightly healthier way through vapes. And we are the second biggest market after America for vape products. And of course, it's an excellent product because it's addictive. So you've got to keep on buying more and more and more of it. And then we've got air pollution. We're doing pretty well on air pollution in the UK. And it's particularly true in London because of public health measures like the ultra-low emission zone. What this chart shows is a reduction in nitrous oxide in London from 2010 up until 2023. And so what this compares is in central London in the green, what would have happened if we'd had no ultra-low emission zone, and in the red line, what has actually happened to the levels of nitrous oxide, and that's measured by, I think it's micrograms, or very, very, very small amounts of nitrous oxide in the air. But this is still very important. Even though it's gone down, there's still a long way to go because of the really big effects of air pollution. It kills 40,000 people a year, according to a report published by the NHS. This is the same thing for particulate matter in London going down, but still a big problem. Now, how we rank internationally, I think, is, oh no, oh, this chart has gone completely, you know what, I'm just going to, this happens with this chart quite a lot. So I've got a PDF. I'm just going to bring that, just give me one moment, pause, and I'm going to bring up a PDF which shouldn't have the messed up chart. There we go. Does anyone know how to make this big? What is it? Control and scroll. Like that? Yeah. But I can't make it sort of full screen, can I?
Use F11.
F11?
Yes.
Okay, well, slightly better. All right, so wait a second. Okay. All right, I'll go back to the slides after this one. Okay, so what we see on this chart is health spending in US dollars compared to life expectancy. So here's life expectancy, 73 up to 85 years old. And here is spending in US dollars per capita, adjusted for purchasing power parity, with a base year of 2010. So that's statistics from the OECD. And then we've got all these countries, and the different colours are according to the type of healthcare system that these countries have. So we've got public insurance systems in green. So that means that it's an insurance-based system, privately run or not-profit, but government is ultimately insuring everything. And that means that they have an incentive to try and keep costs down. The blue one is the NHS style system, the beverage system. If it's a public-private kind of mix, then, like the Bismarck system originally was, it's yellow. And if it's red, it's, if it's orange, it's a private insurance system that guarantees universal health care. And if it's red, and there's only one of these, then it fails to guarantee universal health care. So broadly speaking, we've got Bismarck systems, we've got beverage systems, and then we've got a broken system, which is the United States. And so what you see is, broadly speaking, that if you spend more on your healthcare, you get more life. But what's really interesting is why they diverge here. And so what I do with my students in class is I sort of try to think about what it might be that accounts for differences in healthcare outcomes. Now, if I scroll down, what I want to do, so this goes, do you know how I get it so that it just has one page at a time rather than scrolling?
Yes, make it fit into the window bar.
How do I do that?
Just below properties, there's a icon there.
That one?
Yeah.
But then I want it to go down like,
If you want to put it to a certain size, yeah.
do what?
Use the arrows on the keyboard that can point out the sheet.
Arrows on the keyboard.
This is on the Mac, but if you go far to the far left, those three lines in the far left corner.
Ah, there we go. Got it. All right, so now we can see how the countries change each year. So you can see the UK is just sort of wedged behind Finland there. And of course, there's the United States, and we've got Japan, Spain up here. And so now just watch how the dots start moving. And so we're living longer, we're spending more, but something's happening to the UK. And it's going backwards quite significantly there. So let's just do that again. All right, so here we start in 2010, and sort of press play. Goodbye, USA. So what you see with the UK is that basically we stagnate, but we start spending more. So Finland is going ahead, Denmark is going ahead, New Zealand is going ahead, but we're staying sort of where we are, but we're spending significantly more. And this matches what people know, which is that the NHS is broken. This is GDP per capita. So it's almost entirely the reverse of the first chart that I showed you with life expectancy. America is the richest country, yet we know out of these five that it's got the worst outcomes in life expectancy. Spain is not doing very well in GDP, but as we saw before, doing very well in life expectancy. Australia is doing reasonably well at both, and then you've got the UK and Germany in the middle, although they're flipped before. So that tells you one of the problems with GDP versus measures of well-being. And I just want to illustrate as well, using healthcare, how distortive GDP can be against reality. So if we take the 2021 statistics, United States GDP was $71,055 per capita, and Australia was 60,697. Okay, so it looks like Australia is not doing nearly as well in wealth as the United States is. But then, if we look at the difference in what they spend on healthcare, in America it's 12,196 per person, whereas in Australia it's 6,225. And Australia's, as we've seen, getting far better outcomes in life expectancy. So at the very least, we can deduct $5,971 from America's GDP statistics, because they're not getting the thing that they're paying a lot more for. Then we look at education. So this adds up primary, secondary, tertiary, and of course we know that the American education system is incredibly expensive, particularly at university level, but also it's got a very large private sector. So $15,270 versus Australia's $12,191. And so you do the maths, and that means that you can deduct another $3,000 from America's GDP statistics. And then if we also add in, which we have data for, the loss from on the Human Development Index measure for inequality. So the United Nations produces an inequality adjusted Human Development Index. Basically because America is more unequal than Australia, there's a 3.2 percentage point difference. And so that is the case for another deduction. And you add that all up, and you get to the result that actually America's GDP statistics should reduce to something like $60,020, which means that they're about $677 poorer than Australia. So that's how distorting GDP is. And that's only on those three things. We don't have statistics that I could find very easily anyway on the extra cost of pensions in America, on extra costs of transport, housing, the costs of mass imprisonment, and that shows you why, although GDP looking very good, America does in fact look and really is a lot poorer than a comparator like Australia or a lot of other countries around Europe because of things like healthcare and the rest of its public services being very problematic. Okay, so we probably don't want to move in that direction. So back to the UK now, what are the different models and options to meet the goals that the Manifesto and Starmer's pledges have set up? So the first thing that you could do on public health is you could use Section 7A to transfer the NHS's powers, to transfer the Secretary of State's powers on public health to the NHS. And then also, and I think that you might need new legislation for it, give the NHS power to make rules that would regulate the causes of ill health. So that would be the food and drinks industry, things like supermarkets and retail of unhealthy food, probably advertising as well, controls on pollution, so exhaust fumes from cars and vans and trucks, things like ULEZ. And you could have, or you can imagine lots of different kinds of systems, but because you can't just give a public body the power to pass legislation, but you could have a system where the NHS proposes legislation and the Secretary of State has to adopt it and lay it before Parliament unless they positively reject it. And so that would overcome perhaps some of the political pushback that you might get from corporations that don't want to be regulated. Another option is that you place social care within the NHS. That's been called for a number of years. And you could solve a lot of the problems with privatisation and the extra cost that has entailed by reducing the percentage back down to where it was, 2% instead of 49%. And also, if there's spare capacity within the private sector, you could introduce a rule that they have to do NHS work, public work, if they are asked to at fair prices. With the private finance initiative, you can easily take away the incentive to use private finance, even though it costs more money, by requiring that the government accounts for the cost of private finance project on its books, rather than saying that when you outsource it, it's not on the books at all. And then you could just scrap private finance altogether. If you add it all up, it's been calculated broadly that PFI has cost an extra £80 billion since its inception for all the building projects than if it had been funded publicly. In governance, you could raise the number of staff elected directors on NHS trust boards and also ICBs. That would help with employment relations and increase democracy with more local council and patient reps. We'll talk about this more next week, but it would be fairly easy to remove tuition fees. It would have a cost, of course, but the benefits would be that more people would want to work for the NHS and they wouldn't feel priced out. And of course, this will have a cost as well, but phasing out essential prices for essential medical, dental and optical services would make access to those services a lot more affordable. A few of the benefits and costs of reform, or mostly benefits. So if we did something about air pollution and doing that through giving the NHS more regulatory powers, then the savings are in the billions. So the Royal College of Physicians in Paediatrics and Child Health calculated that the savings each year for the NHS could be up to 6 billion if we tackled air pollution, because the cost of air pollution to the NHS and treatment for air pollution related diseases is 6 billion a year. And the same report calculated that the overall economic impacts would be 20 billion a year. We would have saved 1.5 billion pounds in the last couple of years if we had not had the strikes. And so improving workplace relations, including through more democratic and governance and more staff involvement, would certainly help with that, as well as just simply raising pay. And cancelling 400 million in tuition fee debt, so not just free university for new nurses and doctors, but relieving the debt on existing nurses and doctors, according to the Nuffield Trust, would be the best way to fill the 40,000 odd vacancies that we have in the NHS at the moment for nurses and doctors. Okay, so our discussion questions for today are just what we've been over, but to recap, what's the best mechanism for governance of the NHS between integrated care boards and foundation trusts particularly? What's the optimal level of balance between public and private finance or ownership in the health service? And what could be done for better prevention of the causes of ill health? So with that said, I'd like to invite Becky and Johnbosco to come down, and we will kick off the conversation. So warm round of applause. Would you like to sit? You sit in the middle, Becky. Okay, great. So thanks so much for being here, and I gather your Channel 4 News interview went well?
I hope so.
Okay. So just to introduce you again quickly, so Becky, Professor Beck and Malby works at the University of York and has served on the West Yorkshire Integrated Care Board. Becky is an expert in health innovation and years, and we met each other through water industry reform, but it turns out that Becky does lots and lots and lots of things, so it's great to have you here today. And Dr. Johnbosco Nwogbo is a campaigner with We Own It, which is a campaign group focused on public ownership. And I think you're a philosopher by background, but this is an area of your specialism too. So perhaps I can start with you, Becky. I mean, we talked about integrated care boards, and you've been working on the integrated care board. There's lots of governance reform in the NHS. So when the 2012 Act came in, area health authorities or health authorities were replaced by smaller clinical commissioning groups, and those were designed to put the experts, the doctors in charge. And that was a lot of bureaucracy, and then they were kind of replaced with these bigger integrated care boards there. I suppose they are mostly accountable to the Secretary of State centrally. But I mean, what do you think is the best way to? I mean, have we got a governance system now that's sort of settled with the way that integrated care boards work and foundation trusts, or should there be another round of governance reform?
So I'll sort of step back a bit, which is the two things that are, back to a staff base in the NHS, two things that were major problems. One is the Landsey reform, so it's commissioning private sector, purchase provider split, absolutely disastrous for the NHS, because the NHS doesn't really know how to commission, doesn't know how to buy services from each other. And the point of CCGs was to get doctors to be buyers as well as providers. I thought if they own their own budget, they might behave more sensibly. As many of you, I work a lot in general practice and primary care, and one thing was absolutely clear is that Most doctors really, even when it's their own business, are absolutely rubbish at money. So even general practice don't really know how to manage their finances and make money. They're little small shop corner businesses, but they're not particularly good at it. So that model of beginning to try and put doctors in charge, it just didn't work and doesn't work. And commissioning doesn't work because it tended not to recruit really good folks to do it. And the NHS, at the end of the day, there's more. If you've got more supply than demand, then commissioning works. But we've got more demand than supply, and always have done. So it just took masses of energy out of the NHS and masses of management capacity and points it in completely the wrong direction. And we've had to really pull that back. And integrated care was the first step to do that. NHS is never managed without a regional tier. It needs a buffer at that sort of level between government and delivery. It always has done, always should do. And having that back in place is a good thing. So that's the first thing. Austerity was the second major damage to the NHS. And austerity not just in NHS funding. So the things that got lost over the 14 years of the Tory government, one was capital. So if you look at some of our hospitals, I mean, if you go to my local hospital, it's propped up with props. It's a rack hospital. It's been waiting for funding for 10 years. It's about to fall over. 2030, it's not viable as a hospital. It has emergency procedures to get people out if it collapses. We're at that stage. But it's still not, the funding is still not agreed. Even with West, the funding is still not agreed. So the lack of capital investment, the costs to the NHS of maintaining with props and daily inspections by health and safety people, and the cost to clinicians of working in with ceilings falling in on them in theatres while they're operating. That's exactly what's happening in these places. No one talks about it. Those sorts of conditions are absolutely scandalous for a developed country. So we've got those two major issues: austerity, not just in terms of NHS funding, but in terms of people's health and well-being. So when you talked about poverty, we tend to sort of work around the edges. If you look at a major increase in childhood admissions to hospital, it's a result of dentistry. It's about no access to dental health when children are young. It's caused the most incredible infection rate and incredible paediatric admission rate in hospitals. So if you're thinking about prevention or where you might put our efforts or where we, whatever the damn governance is, if we look at poverty, what we see is that people in poor communities are getting less at every level. And it's because they don't have you can do what you like around supermarkets and foods, but basic income means people are in levels of distress, mental health distress, food poverty and distress, work poverty and worklessness, levels of addiction and drug abuse, mental health crises in our poor communities is absolutely horrendous. And our poorer communities have less access, so they tend to use ambulances a lot more. Again, if you look at A&E attendance, your major increases around people who are poor. If you look at where general practice is provided, there is more funding per head for general practice in wealthier communities than there is in poorer communities, because the funding formula for general practice is about age. So older people get more, they tend to live in wealthy communities. Our poorer communities are young. Young people are absolutely ignored in our whole system. We are not good as a society with young people. So if you look at the overall money we have in the NHS to spend on young people, where we have this huge increase in mental health, the absolute disaster around ADHD, autism, and mental health and anxiety for young people post-COVID. But it was starting before. If you look at waiting lists, which were going up before COVID, everyone blames COVID. It is not COVID, it's absolutely austerity, absolutely Tory policy. We were doing well before then, but as soon as the Tory government came in and chose to absolutely asset strip the NHS and to really create a fight with doctors because they think they're some sort of professional mayhem. Once we did that, we absolutely got lost. So the things that are really stressing the NHS at the moment, poverty is a massive stress. And you can put the right things on supermarket shelves, but we're not educating children properly, we're not putting support in families. Getting rid of Sure Start, a disaster. So that's the first thing. Second thing is staffing. 75% of the NHS as permanent staffing, the rest is all extra staffing, agency, bank, whatever we can cobble together in vacancies. So it's phenomenally understaffed. The strike was a complete disaster for the NHS. It cost June to July. Thank God they sorted that out. That enables us to do some elective care recovery, but we couldn't tackle waiting lists while staffing was at the level it was. Social care funding, I don't know about putting it in with the NHS because I think hospitals will suck it up, it will destroy the prevention agenda. But we've got, you'll know, local authorities across the country are bankrupting. So if you take the amount of millions and millions that's been taken out of local government, there is nothing left for social care. So we did a fantastic job of keep people alive. We keep people alive for a shit old life, actually. So what is the point? We've got 90-year-olds having the most grim life because 67% of people who live over 80 are not having their care needs met now by NHS or local government because primarily they're not helpful needs there. Social care needs, we have nowhere near enough money in social care. So what was the point of that? So you have this bizarre process of trying to hang on to people and keep them alive, but at the same time we're not doing anything about the future health of our young people, and we're not looking after our old people well. You know, the biggest costs of health are people in the last years of life and the first years of life, and now we're beginning to move that on. So the biggest costs of health are actually right up into teens now, because our young people are so poorly recorded. So the issues are huge. So then when you look at the governance and regulation of that, actually I think ICBs are not a bad way forward, except they're totally hampered by barking mad policy from NHS England. So NHS England is not steeped in the problems of local communities. ICBs actually are. They're pretty good at trying to handle the postcode lottery. So CCG's creates a huge postcode lottery. If you go to West Yorkshire, the difference between what was provided in Wakefield, in Leeds and in Bradford, for instance, was all about historic funding patterns, historic behaviours. There is a level of beginning to bail each other out across those places. Really, really good governance, I think, getting into those places and collaboration so that we have something that's fair for everybody. It's really slow, but it doesn't help when you get nutcase policy from NHS England. I was telling you earlier, we're being told that we have to fund the obesity drug. The obesity drug costs £3,000 per year per head. If you fund the 250,000 people eligible for the obesity drug in West Yorkshire, that is a phenomenal take on our budget. And that's because NHS England says you have to, because NICE says it works, it helps reduce obesity. I'm sorry, what helps reduce obesity is people eating properly. So what are we doing about that? So I ask that the board, can we please match that with £3,000 a head for young people who are at risk of obesity because of poverty? Can we put some money in their pockets so they can afford good food? Can we do something about health coaching? Can we get them out so they can play football, in a local park together? That would be good. Put short start back in. Why aren't we matching that? And absolutely can't do that because that's how it's been dictated, which is the sort of sticking plaster. Yeah. So NHS England policy is difficult. At ICB level and ICS level, you've got a much better collaboration between local government and the NHS and Health Watch, really good public involvement. So I think you're seeing much more of that in those ICBs that are forward thinking, have those collaborations. You go to North West London, I shouldn't speak out of turn, but I don't really care. It's an old-fashioned ICB, and so it doesn't have the same level of collaboration. So it's stuck in the get-a-grip financial control model, rather than how do we get to good health outcomes and the finances will follow. It's very tricky doing that in a government-regulated NHS England Treasury-dominated model, which is all about grip and growth. Some of the stuff you put there, which is nothing to do with it.
If I could just ask one quick follow-up question and go to Johnbosco. There was this kind of logic to Andrew Lance's reforms that you put the experts in control, you put the doctors in control, even though the doctors just didn't want to do the financial stuff and weren't very good at it, and then there were regulations saying that they had to have a finance person there. Some of the things that you mentioned, obviously having a fight with doctors is not very counterproductive, but at the same time wanting them to be involved. And you mentioned this idea that ICB is more effective if they collaborate with other communities. So we've got these stakeholder groups, we've got the public interest, we've got the staff who probably know best at some level, where the needs are when the building's falling down, where the healthcare concerns are, and then you've got the local community who also knows about their needs. So I mean, do you think that there's a role for more stakeholder representation on ICBs and foundation trusts, or not?
Yeah, definitely. So the bit that the NHS is not good at and local government is good at is collaborating with communities. So, there's sort of those of you that know all about co-production and how you can, most care takes place in people's homes, it's seen by carers, it's not done by anybody in the NHS. But the founding model from NIBEGM was, can do, should do means treatment means cure. And that has absolutely no use in a preventative model or a chronic disease model. Prevention of chronic disease management requires a phenomenal collaboration with voluntary community sectors, with people in their homes, and I guess the integrated enablement teams and some sort of board process is to get closer to that. But the NHS historically, and clinicians in particularly, have always been about doing for, not doing with. And that's a phenomenal cultural move that needs to take place. So if you go out to these newly formed primary care networks, lovely, and then learning still how to just collaborate across GP practices, the 101 shopkeepers that are trying to do front of house. If you go and get the gatekeeping to the NHS right, the whole rest of it fails. We put so much effort into hospitals, we put nowhere near enough effort. So if you look at management costs, overall, across corporates in the UK, it's about 9%. If you go to hospitals, it's about 4% management costs. If you go to primary care, 1%. They have really very little management, very little comms, very little financial support, just how to run your business, because they're quasi-NHS, quasi-not. If you could properly, I think before prevention, I've been putting money into general practice and primary care to help them develop a model as they're inching to of collaborating, some things at scale that need to be across general practices, some things within general practice, and helping them collaborate with communities. So on Monday, I'm out working with a group in York, a group of general practices who have no idea what's going on in their community in terms of their voluntary community sector, who they could ask for help. So one of the emerging risk factors on the ICB board, I chair the quality committee, we just got on before I left, was domestic violence. We're seeing a massive increase in domestic violence. GPs have not a clue what to do about domestic violence, they don't know. But there's loads of voluntary community sector and local government, knows a lot about how to handle domestic violence. So if they partner with them, they could probably do something about it. But because they don't even know who's out there, I think we need a website directory so I can pinpoint a few. They don't form the relationships because they haven't got the time, they weren't sure it was their business. If we could support general practice to be much more embedded as it used to be in its community, we've probably got a chance of collaborating to manage some of those sorts of issues. So that's where, so I think prevention, let's start with Sure Start, let's start with general practice. There's some practical things we can do that worked before, and let's learn some of those lessons.
Great. Johnbosco, there's so much there on the table already. I mean, obviously the NHS is focused on making sure that the NHS is public, and we can see that in the statistics, life expectancy starts stagnating around 2012 with this act, pushing in a lot of privatisation in the NHS, a lot of outsourcing. There's all sorts of other things. I mean, just perhaps I could ask you to speak broadly. What do you think the priorities would be for fixing them?
Yeah. I thought I should probably start by kind of saying a little bit about prevention. Because while she was speaking, I was thinking about the Commonwealth Fund is this American think tank that produces research that ranks healthcare systems across the world. And what was really interesting was that during those years that we were showing life expectancy stats stagnate in the UK, the NHS was being ranked as the best in the world for a lot of that period, right? 11, 12, 13, 14, 15. I believe only 16 wasn't, 17 was. It was the best healthcare system in the world. And I think if you want to talk about prevention, we ought to recognize the kind of social change that happened during the financial crisis or following the financial crisis. The fact that politicians thought that their response to it should be cutting the things that give our lives meaning in our communities, right? Cutting services for young people, cutting things that are not immediately needed for, I just broke my knee, I need that thing taken care of, right? If it's not immediately needed for that, I'm going to cut it. And you spoke about fixing hospitals. the NHS has about £13.8 billion repairs backlog at the moment. Why does it have that? A lot of the money in the purse for that is being transferred to fixing people breaking their knees and all of that, right? So there is a fundamental societal change that happened as a result of that. And I think when we think about the 2012 Act, we have to think about it in the context of that, right? And obviously, one of the most important parts of it, for me at least, and I recognize that different people will say that different parts of it are more important than the others, was Section 75. It was a section that essentially required NHS bodies, at the time CCGs and now ICSs, exactly to put out to tender services of beyond a particular value. And what the effect of that ultimately was that it created a kind of market system within the NHS. You mentioned, I forgot who mentioned, might have been you or you during your presentation, the providers commissioner split. That did not exist until 2006, if I remember correctly. That was created then. That was when NHS trusts were created. The NHS wasn't born with that, as I understand. And obviously, the problem with that is that we waste, according to one analysis, £4.5 billion running the market that was created by that. But there are other problems. Well, of course. There are other problems, of course. The fact that we just carried out research, actually during the general election, we only did, that found that private companies who run services within the NHS make about £10 million a week in profits. Just profits, not revenue. And you mentioned a moment ago scrapping the debt for people who are nurses in the NHS at the moment, 4,000 of them. We found that would scrap it like 7 times if you scrapped privatization within the NHS. So I think one of the things that we think should be a priority for this government is, I mean, we don't believe that they should flip their fingers and end privatization. We believe they should put the NHS on a path toward not relying quite as much on the private sector. There are services right now that the NHS should be doing that the private sector does the majority of. Ophthalmic services, for example, knees, hip replacements. Maybe not the majority for that, but yes, right. So we're seeing the NHS move in a direction that is going to lead us more in the direction of what they have in the US, where much of the money comes out of the government's pocket. When we talk about the US, so we talk about private health insurance, but we should be talking about Medicare, healthcare for the old, Medicaid, healthcare for the poor, Veterans Affairs, healthcare for veterans. That's the vast majority of what the government in the US does outside of the military, right? And we're moving in that direction right now with private companies doing much of the provision, but much of the money coming from the government. And just to highlight a little bit what you mentioned earlier on about the difference between the kind of impact privatization between people in different parts of the country. A recent analysis from the University of Newcastle actually found that the government's solution for the huge waiting list, which is using the private sector to cut waiting lists, it's actually more than doubling the treatment gap between the richest parts of the country and the poorest parts of the country. For one simple reason, private healthcare companies want to put their hospitals where they're going to make the most money. Where is that? Where the richest people live. So if you're saying my solution to this huge waiting list is to give them as much money as possible to fix waiting lists, what you're going to find is that they're going to fix waiting lists where they exist, and we're going to double the problem that we have already of the treatment gap between the deprived parts of the country and the richest part of the country.
And I don't know if you've done any analysis, or maybe more. My experience anecdotally is that a lot of people that are doing the private work are also working for the NHS.
Yes.
They're just sort of putting a different hat on, which logically is only depleting from the NHS work that they're doing.
But don't forget, some of that's about capacity in the NHS. So you can have cardiac surgeries. If you haven't got the theatre space, they can't operate. So when they've got, you have got quite a bit of redundancy in the NHS in terms of clinician staffing, because you haven't got the nursing staff, you haven't got the anaesthetic supporters, because we've got this huge vacancy rate in the NHS. It's not so high with docs. They've got spare time, and there isn't the theatre time or support to do it, so they do it in the private sector. So it isn't just that, I mean, they are out to make money, but it's partly because we don't have the capital space to do the stuff, to do the electives. But if you look where I think we've probably got the bits that tend to be overlooked in terms of private sector work is actually general practice private sector, don't forget. Dentistry, we're putting that back into the NHS. It's costing us a fortune because we lost it during the Tory government. It was a disastrous thing to do to privatise all of dentistry because absolute teeth is so fundamental to people's health. So we're having to pull that back in at a big cost. You're absolutely right, but that is becoming really nationalised again. Yeah. And the other thing is care, older people's care. So most of care services, there's some running within the NHS and some run within local government. There's an awful lot of private care sector providers. So people think of private sectors as hospitals and big hospitals doing electives. Actually, there's massive private sector work in smaller businesses that don't sound really expensive until you add it up. So one of the issues about, say, people living longer is that we haven't absorbed or thought through the costs of all of that. So I think you have to think of the private sector as quite a big umbrella, and then you need differential ways of managing that. It's not all the same thing.
Yeah, I just wanted to add to that quickly. Obviously, I think it's fair to say that primary care is private, so to speak, right? We have GPs who are, I think it's probably safer to call them independent rather than private, right? Because I think until 2006, they were not allowed to take patients that were not NHS patients. Right? And the government decided pretty much all of what they did. Their biggest contract is the NHS contract. Yeah. That's not a normal business, right? The same thing with dentistry. So in that respect, I think the NHS is such a unique body. It's not like, I always think about past governments, the Tony Blair government, for example, wanted to bring in this newfangled tech system into the NHS. I think they spent something like £8 billion on it. And they had to scrap it because apparently the people who designed it did not know what the NHS worked like inside the NHS. Right? So I just thought it was really useful to kind of mention that the NHS is weird, but brilliant as well.
But I think you're right. I think in terms of just looking at our spend as the ICB, I think the bit where we're most likely to get it wrong is the tech. So when you think because NHS isn't very good at buying some of that stuff, it's not very well informed. Yeah. So new tech, where there are really good solutions out there, but at a price. It's the same with pharmaceuticals. There's some bargaining power, but we probably overspend on a lot of that stuff. So I think if we're looking at, I'm sort of slightly less worried about this focus on elective care. Good thing about sometimes some of that private sector provision creates tension in the NHS that goes, oh, I don't want that money to go over there. I'll increase it. So when you look at it, every time we put elective care type models in, we've had all sorts of drop-in centres and walk-ins and all sorts of things. They don't last very long because the NHS goes, oh my God, I don't want the money to go there, I'll do something about it. Hospitals are better at that. It's the stuff around the edge which I think we're probably going to spend a lot of money on badly, and tech's one of them.
I've got like 1,000 follow-up questions that I could ask both of you, but I'd like to ask people here if they'd like to comments or questions. So Gwyneth, and then gentleman here, and then
Yeah, you've got a problem here, Ewan, because we're all experts on the NHS, because all of us have had interactions and all of us can have views based on it. Yeah. Two things I'd like to talk about. One is free versus paid for. And I'm thinking also of the intergenerational fairness point, which Becky raises, and I think it's very important. Don't forget that people who are pension age get loads of stuff for free, regardless of what our means are. The government slightly addressed that with the winter fuel allowance, thank goodness. But I mean, I do wonder about the amount of things that older people get for nothing. And also the general thing that if you get things for nothing, do you value them in the same way? Do you make better choices if you've got to pay for things? And I kind of think that psychological element. Whether, one, can we afford to have an NHS which is completely free? And if we don't, the pay for thing does have sort of some nudge effects, I think. And I think that might be relevant. The other thing is about governance. And I spent 10 years on NHS boards, actually, in Yorkshire. And it seems to me that quite often, well, one, I'd love to know whether there's ever been any consideration of whether boards are valued for money, boards of directors and non-executive directors. But also there's this element of the centre saying, okay, I was disappointed that they went for targets again. Whereas Skidmore talked about targets again. And all that does, it seems to me, is set up management and boards to get in conflict with practitioners, because practitioners know what is needed, but the boards have got to do what the government has asked them to do in terms of targets. So you just get a clash. It doesn't resolve itself